I'll send you a copy of this,
Yeah,
just to remind me.
that's great.
So this is just, if you have high opioid or benzo tolerance, these are the things that we found cause trouble, right? This is why if you start doing this, you're going to stop ending, you're going to start ending those others. Greater than 300 pounds, obvious. Severe cachexia and a prolonged time with no oral nutrition, right? So the lack of nutrition. Use of anticholinergic medicines. A lot of people are on medications that are for nausea. How does the nausea medication work? It delays gastric emptying, right? So having delayed gastric emptying is a risk factor. Extreme exercise history, poorly controlled nausea or vomiting. So the case that, if I've got this right, the case that Tony had up in Oregon was a patient, if you look back at her history, she was complaining about nausea continuously, right? What is nausea on a functional anatomic level? It's pre-vomiting, right? If vomiting is the stomach reversing and going up to empty itself, nausea is the stasis before vomiting, where the stomach doesn't empty. So if somebody has persistent nausea, before we do a medical aid in dying, I'm going to stop that case now. I won't do it until the nausea is under control. Because if somebody has nausea, I don't think they're going to put their medicines in there. Get it under control, either pharmacologically, steroids. There's a lot of ways
to improve the uptake of.
That's right. You want to get the medicines to work. If they're telling me they've been nauseated for the last 3 days, or had one episode of vomiting, but the nausea continues, I don't do it. Right? What we're trying to do is say, I know now what the risk factors are. It's a patient problem, not a pharmacology problem. Right?
And there's drugs that easily control.
Yeah, I'll put them on Decadron 20 milligrams
Okay.
for 2 days
Okay.
and get there and get it under control. I can do that. And I won't use medications that stop the gastric emptying like Haldol and some of the others that are used by hospice. So this is why I have to be involved in their care. This is also why you don't do prescribe and abandon. Because if you prescribe on January 1st and they don't take the medicines until March 1st, which is common, then you don't know what they're like at the time they took the medicines. That's like saying, I'm going to prep you for surgery on January 1st and do your surgery on March 1st. A lot could happen between now and then. You need to keep up with the patient. And this is also why I want hospice to be the docs who are doing this, because they do keep up with the patient. The nurses get out to the homes, they ask about nausea and vomiting, you follow it. If on the other hand you're the oncologist and you said, okay, here's the prescription, we'll put you in hospice, and then you don't continue to follow the patient, because oncologists don't follow patients they're not doing chemotherapy and other shit on, right? That we know. They lose those patients. But if an oncologist will write this, my insistence is, and that's what's happening with Lowell, is I'm saying you must follow the patient. Right? We have patients who've taken these medications who've had bowel obstructions. Right?
Is there a morphine or something?
Well,
They're constipated?
No, they have this one lady, the most serious case was a lady with ovarian cancer who had metastases in her abdomen. The metastases finally crimped the bowel. She knew she'd had prior bowel obstructions which were alleviated surgically. She knew about them, surgically rather. So she had surgery for bowel obstructions from her cancer compressing the bowel. They decompress the bowel's functioning again. They send her home. She has medical aid and dying medication, Seconal at home. She develops another bowel obstruction. She says, oh my God, this is terrible again. I don't want this. I'm going to take my medical aid and dying. You can't take medical aid and dying or anything if you have a bowel obstruction. Your bowel's not working. So a wise nurse called us and said, what should we do? Because here's what happened. The nurse calls, this is a Kaiser patient. That's off the record.
So the nurse tried calling Kaiser.
Nurse tries to call Kaiser. She gets the doctor on call and says, I didn't write that prescription. I don't know anything about medical aid and dying. I can't help you. The nurse then calls us and we say, stop. You can't take medical aid and dying. So 3 months out, the Kaiser doc wrote the prescription 3 months before and also delivered the medications, because that's their policy. That's a whole other conversation I want to have with you about when to deliver medications.
Yes, I'd like to have it.
But they deliver the medications, the patient is sitting there with them, and the patient makes the decision when to take that. So, but the entire physiology of the patient has changed in that 3 months and should not have taken the medications. So we tell them to stop. We call Kaiser and we say, what are you doing? Giving the patients, not tracking your patients. At least learn a lesson from this. And the patient with the bowel obstruction doesn't get to take her medications, and she dies the next day. She should have with hospice sedation and all the rest. The point is you got to be there. Somebody has to be there on the day of the death to evaluate the patient, right? So anyways, we're back at the red flag checklist. We have severe constipation as another indication. Past history of IV drug use, which I think is very interesting. Why do we say that? Because they're probably going to be opiate tolerant, even if they tell you that they haven't had any IV drugs for the last 10 months, they probably have. Mental health issues that you think makes them inconsistent about their drug use reporting, being very young, very healthy, high rate of alcohol use, any GI disease, including pancreatic cancer, swallowing difficulty, and then what we just say is, if there are significant red flags, here's our policy. Case discussed with. You must discuss it with another doctor, preferably with a doctor who has equal or more experience than you. So if Linda and I, this is
or like
even
a GI
in our
doctor,
depends. No, it just depends.
Just another doctor.
Yeah, you have to say, here, I think I have some risk factors, right? In our practice, if it's Linda, she talks to me. If it's me, I talk to Linda, right? We want, and we've set up a system with about 4 or 5 docs who do a lot of this, where we will talk to each other. If we see red flags, we'll call each other up and we'll say, hey, what do you think I should do? And sometimes, rarely, what I will say is this patient is not a candidate for medical aid and diet. You can't do it.
GI issues.
GI issues. We had one lady who we tried, and if in retrospect now, she never should have done it. She had a bowel obstruction from not an ovarian cancer, from a primary uterine cancer. Had a bowel obstruction, just like I described to you. But when they went in to fix her bowel obstruction, they also took out a good significant part of her rectum because it was involved in the cancer. So I called the surgeon and said, you had your hands on that rectum. What do you think the condition is of the rectum now for absorption? Did you change the blood supply at all? Whatever. He said, no, that rectum is going to be fine. Don't worry about it. What I don't think that doc got was how much we put into this rectum. And she had a really complicated death. So in retrospect, in some cases, I think we're learning now we should call off. Really rare, but I think sometimes we should just say, no. High opiate tolerance combined with exercise difficulty, with GI disease. You just got too many things that say this is a person who has a risk of waking up.
And if you could do intravenous medication, you wouldn't have to worry about any of this.
That's right. This is all us trying to work with the gut. Right? I'm telling you all this because we have to work with the gut. Otherwise, we'd have a whole different story. So the moral of the story is my whole idea now is we do have problematic deaths. We do see long deaths. We do see some awakenings. It doesn't matter whether it's seconal or DDMP2. Okay? DDMP2 tends to do it less, but it does it. Right? And it's not a problem of the pharmacology, it's a problem of the patient, and we need to now start recognizing in advance who these patients are and deciding what to do. Right? So I'm using a lot of rectal chlorohydrate right now. Chlorohydrate is the medicine that they couldn't take because it burns so much. But you can administer it rectally instead of orally. It burns the mouth. It's terrible. It's awful stuff. Think about like drinking turpentine.
You use it in addition to DDMP2?
Yeah. Yeah, if I have mostly this, right, very high opiate, we can see people on 200 milligrams of morphine a day, right? They are so tolerant. I'm not convinced that morphine, right, that hitting the morphine receptor is going to be functional. And then we have the benzodiazepine receptor. We have 1,000 milligrams of Valium, which isn't that great. And we know historically the Valium is not a very good respiratory suppressant. It's a good sleeping medicine. But chlorohydrate hits a totally different receptor. So if they're on high opiates and I need to hit another receptor, chlorohydrate is a really good drug, except it's so hard to swallow. Right? So I'll just tell the patient, I think you're at very high risk. So what I'd like to do is insert a rectal catheter. Just about the time you're dozing off, you push on my hand and we'll push in the chlorohydrate because it does burn somewhat in the rectum, but there isn't the taste and it's a terrible thing to take orally.
The seconal too is also bad to take orally, isn't it?
I have, so here's my confession. I've never written a prescription for seconal.
Okay.
I never will.
Because pentobarbital is very bitter. I didn't have seconal.
I don't know. I can't get any pentobarbital, so I can't legally use it. Right? It's not. You can't get it in this country.
There was one story I heard. It was like, this doctor was telling me about how he used to help patients in like the 90s. I need this paycheck.